All right, it's just after 7, so I think we'll make a start. Good evening, everybody. Welcome to part 2 of the Shared Maternity Care Collaborative Workshop. Hopefully lots of you made it last week and got a great learning exercise with Vicky and Rachel's presentations. This week we are kicking on with gestational diabetes and pregnant women above and below healthy weight. My name's Karen Ahrens. I'm a GP in the Macedon Ranges and I work at Western Health in the integration unit and with the shared care collaboratives. So before we go any further, just would like to acknowledge the countries that we're on. So in conjunction with Northwest Melbourne Primary Health Network, the Royal Women's, Mercy Health, Western Health and Northern Health, I'd like to acknowledge the traditional custodians of the land on which all of our work takes place, and that covers the Wurundjeri Wurrung people, the Boonwurrung people and the Wadawurrung people. And we'd like to pay respects to elders, past, present and emerging, and to pay respects to any Aboriginal or Torres Strait Islander people who are in this session with us today. So, actually, I'm going to move. Don't get excited, I jumped too quickly. So before we jump onto that, I'd like to introduce some of the other people who are on the panel today with me. So you will have met some of them last week. So we've got Joe Silver, who's a GP in Point Cook and also works at Western Health in antenatal and with the integration unit and shared care. Hi, Joe. And we've also got Ines Rio, who is a GP obstetrician and the head of the GP liaison and shared care unit at the Royal Women's Hospital. Hi, Ines. We've also got Arzu Khalid, who's an obstetrician at Northern Health and who runs the shared care program out of Northern Health. So thanks for joining us, Arzu. All right, moving on. You will have all seen this last week, but just to remind you, it's a Zoom webinar, so you're all muted. But as usual, we're really keen to get questions and answers, Q&A, or questions mainly. We'll do the answers bit, hopefully, or the presenters will. So please ask those questions in the Q&A box, please. So you'll see that there's a Q&A and a chat box. Dodge the chat box for your questions because we won't see them there. And throughout the session, Joe and myself will be facilitating those and getting the presenters to help with answering those. And if there's some that we can answer in the chat and have a chat with you, we'll do that as well. You'll see there's a box that says send anonymously because this session is being recorded. You are very welcome to untick that box if you wish to be identified, that's fine, but that's the default position. As per last week, this will attract CPD points for pregnancy. And so if you wish to be included in that and you think the name that you've dialed in on your Zoom is not going to be identifiable appropriately, please, that's when you can use the chat. So please write in the chat and send the NWMPHN little note to say what name you're really using or would like to use so that you can make sure you get those points. And if you're not quite sure, just send the NWMPHN Education a little question and they'll answer in the chat. As per last week, there's a link to the evaluation at the end of the session. Thank you so much to everyone who answered the evaluations last week. We really use that information. It helps us enormously. And in a week, the PowerPoint and the links to the recordings of this session will be available. I mentioned the points. Last week was 4, this week was 4. And the evidence will be on your statement in about a month's time. I would encourage you, we've got 2 presenters today, and then at the end we have a little session on some health service updates and resources relating to the shared maternity care space. So I do encourage you to stay on for that at the end. Just a reminder, as always, Health Pathways, no doubt most of you are already using it quite a lot, as it's a terrific single point of reference for clinical and referral pathways and resources. But just in case you haven't come across this is a little bit of information about that. Ines covered it in more detail last week, so I'm not going to dwell on that too long. But all the pathways and the resources and the clinical information is written by GPs with support from numerous stakeholders. And if you haven't registered, this is where you go to melbourne.healthpathways.org.au to register, and it's free. So I'd like to introduce our two speakers. Our first speaker is Dr. Suresh Varadarajan, and he is the Head of Endocrine Services at Northern Health in Victoria, and has honorary positions at the University of Melbourne in some teaching roles. And Dr. Suresh is going to be speaking to us today about gestational diabetes and diabetes in pregnancy. And then after that, we'll be hearing from Associate Professor Glyn Teal, who's the Clinical Services Director of Women's and Children's Services at Western Health at Sunshine. And he's also a Clinical Associate Professor at the University of Melbourne. So I'm looking forward to learning lots from these guys. With no further ado, I'm going to hand over to Dr. Suresh and leave you in his hands. Again, don't forget to put all your questions in the Q&A along the way. We'll do that dynamically throughout the session. Thank you.
Good afternoon. At the start, Suresh Varadarajan is my name. As Karen pointed out, endocrinologist and head of endocrine services at Northern Health. I've been there for about 18 years or so. It was a fledgling service when I joined. We had, I think, one diabetes educator literally at that time, and she used to run the diabetes clinic along with the obstetricians. And one of the reasons I actually was asked to start work there was the need for the endocrinologist and somebody who had an interest in obstetric endocrinology. So that's my start in 2004 or 5 and thereon. I'd like to again acknowledge the Aboriginal elders, past, present, and emerging, in the lands that I am and we all are, and also like to pay respects to them if they are in the session with us today. So I'll start sharing my screen, which is here. Where am I? Share screen. Okay. Actually, hang on, I've got to stop and then fill this up. And why is this not letting?
It came on the screen.
The whole thing, did it come, Karen?
Yeah. Oh, no, just the...
Yeah, just as a...
Yeah.
So
if you go up to the top, yeah,
now?
Good to go.
Okay, good. All right. So we'll start off by essentially just going over gestational diabetes care in the shared care model, but primarily in the hospital. And I would actually like Dr. Arzu Khalid, head of ONG at Northern, to pipe in at appropriate times, because sometimes, as you will find out over the course of my talk, we get to see only the pointy end of the diabetes spectrum in pregnancy. And we probably, at least the endocrinologists don't get to meet everybody. So we'll start with the way it generally run, and I'll hopefully have a couple of case studies to also illustrate the point. Okay, so this article that appeared in the Lancet Diabetes and Endocrinology just 18th of October, and the lead author, Dr. David McIntyre, is from Brisbane, and he's used a word which I think I hadn't thought about, but maybe subconsciously I do agree with the fact that gestational diabetes is becoming a bit of a tsunami. And I think Glyn and I would agree, where we specifically work, it's even a higher representation of people with gestational diabetes and type 2 diabetes than some other parts of Victoria, for example. So in line with global trends, the incidence of gestational diabetes has increased markedly from a relatively stable rate in about the first decade of the century, 5.2% in red in 2010, to 14% in 2015, and then 16 in 2018. The 2010 to 2015 comparison is quite relevant because it represents the time in which the criteria for diagnosis changed. It went from this glucose challenge test and then going on to an OGTT to directly going on to the universal OGTT. But I think it was done more often in the 26 to 28 week mark. So before 2015, a non-fasting GCT, so women would just rock up in the middle of the day, have a 75 gram glucose load and have a 1 hour post, and depended on that level was either deemed to be normal or went on to have a formal fasting 2-hour glucose tolerance test. And even the diagnostic criteria at that stage was 5.5 in the fasting stage and 8.0 in the 2-hour mark. That also got changed subsequently to the one that I've highlighted here in red, which is what we're currently using now. And those initial testing was done by I'm just going to mention the initials, International IADPSG in 2010, and it was endorsed by the WHO in 2013, and that's what we currently use. Temporal data clearly shows it was factors other than just the revised diagnostic criteria that contributed to the increased incidence of GDM. The key identifiable drivers in the rise of this GDM in Australia include what I think is one of many factors: increasing age at which women are having children. Even though the mean says it's just gone from 29 to 30 in about 13 years, that's, I think, quite significant. An increasing prevalence in the percentage of people who are overweight, women, of course, and obese, which apparently now amount to about 27% of overweight and 22% in the obese category in 2010. And I'm sure Glyn will have something to say about this as well. The other, probably in my opinion, and where I work, the demographic change is largely related to immigration, I think, has led to the biggest jump. The reason is women who come from areas with a high prevalence of type 2 diabetes, Asia, North Africa, and the Middle East are the reason for the bigger jump of late. Moreover, local variations in ethnicity, prevalence of obesity have also led to geographical differences in gestational diabetes incidence across Australia. They gave an example in Western Sydney. The change from the historical AIDPS to the international criteria increased the estimated incidence of gestational diabetes from 15 to 30%. That's a massive doubling in 2015. The lowest increase, just 3%, was observed in women from East or Southeast Asia, compared to the doubling of diagnosis of gestational diabetes from 22 to 44% in women from South Asia. The wide divergence, coupled with the socioeconomic disparity that characterizes such regions, meant that people like us in the urban areas where these people who are have higher predilection for diabetes actually live, makes more increased pressure on us to deliver best practice care for women with gestational diabetes. Now, just going to diverge a little bit to First Nation women and remote and rural Australia. They also have very similar, in fact, probably slightly worse issues. The First Nations women experience higher age-adjusted rates of gestational diabetes, relative risk of 1.3. Anything more than 1 is pretty significant. And management is complicated by geographic isolation, socioeconomic deprivation, and limited food choices. The need for insulin, similar to those of the overall population, so I'm just going to move something away. 29%, but the use of oral hypoglycemic is much common, 14 versus 7, reflecting the pragmatic approach to management in these people. There's 1 or 2 points that I'd like to highlight in the next slide. The First Nation women also experience higher rate of progression to type 2 diabetes following pregnancy, with about 42% compared to around about 25 to 30, which is overall statistics for, as a group, people who have diabetes in pregnancy going on to have gestational diabetes. And the average years is about 7 years from the time after delivery. Now, these, of course, will require culturally appropriate policies and interventions to prevent type 2 diabetes and associated complications. The management of this, of course, includes lifestyle modification, home glucose testing, which I will refer to as SMBG, self-monitored blood glucose, and depending on where the level of dysglycemia lies, you use insulin or oral hypoglycemic if the glycemic targets are not achieved, following the usual initial startup of diet and physical activity changes. Current Australian practice, we use a lot more insulin than the original trial, which is by Crowther from South Australia. And that is a huge trial that I'll be talking to about in a little bit of detail, called the HAPO study, which changed the way we manage things, 20% and 10% respectively. Insulin therapy, this I kind of disagree, because you really have to tailor who you're managing. their statement was insulin therapy is likely to be used in older women and those living in urban areas, that I do agree, which reflect their access to tertiary hospitals. Metformin, of course, is the only agent we still use widely for gestational diabetes. The use varies across different centers, more frequently in remote and socially disadvantaged. And I put this in red at the bottom just because I think the way we do it at the hospital, and we generally teach the junior staff going through, it will be insulin that we would advocate. And then if the patient either got needle phobia, scared of insulin, etc., so it'll be much more patient choice rather than us. And of course, in the wide, the remote areas, that's a different story altogether. Now, this is just the last point. I think the rising prevalence, this is partly the reason for giving the talk, which is to de-stress the very stretched maternity services in tertiary hospitals. The rising prevalence has led to major stress. In response, most tertiary hospitals have adopted this model of care where they have group sessions rather than individualized diet and education sessions. And they call this a step-up model of care whereby specialist MDM or multidisciplinary antenatal care clinics are reserved for women with high obstetric care needs, early gestational diabetes, high-risk obstetric history. In these settings, the majority of women with the gestational diabetes remain within their primary antenatal care, antenatal team, and in the low-risk model of care. Now, this, I think, really pertains only to the last 2.5 years, i.e. COVID. Telehealth and mobile health solutions have increasingly become part of routine care, spurred on by the restrictions that the COVID-19 pandemic brought upon us. Most of these practice modifications have been well-intentioned but empirical in nature, and they reflect just pragmatic responses to resources. Proof of the efficacy, and I put this in red because this is something I completely agree with, as opposed to the last slide where I thought I disagree with. The efficacy will need to be proved in formal clinical trials, or at least data benchmarking of data, and this is urgently required. So to finish up, 2 recent trials. This is just a little bit of controversy. 2 trials from the US and New Zealand have showed an increased detection and treatment of gestational diabetes does not lead to a population-level reduction in associated clinical complications, including large gestational age infants or hypertensive disorders of pregnancy. And those are sort of prime clinical targets for why we do this. However, there was a New Zealand study in a pre-specified secondary analysis showed that the treatment of women with new gestational diabetes, i.e. negative by historical New Zealand criteria, but positive by the new criteria that I've just put up before, resulted in a substantial reduction in clinically important complications for the subgroup. They showed that it decreased a frequency of large for gestational age infants, preeclampsia, and hence shoulder dystocia. I think the most important points in this slide is that and that's going to be one of my main take-home messages. I think we need to, as a group, get better with, someone called Joy has raised their hand.
That's okay, Suresh.
Just keep going.
So Joy, can I ask you to put your questions in the Q&A box, if that's possible? Yeah.
Sure. So the 2 important points, and I think this is where we all need to work together. And I don't have the exact statistics for it, but I'm not sure, and maybe someone else can pipe up if they do, what the exact rate of postpartum OGTTs being completed, done, and ticked off as either normal, hence usual post GDM advice, or found to have type 2 diabetes in Australia, specifically where we work. I think it's something of the order of about only 40 or 35% get done, and that's some number that I've heard in a talk, but I don't know the exact number. I'd be happy if someone else could share that if they are aware of it. So I think this postnatal follow-up for women with gestational diabetes is widely recognized as an important opportunity to improve maternal health, specifically to target strategies to prevent progression to type 2 diabetes and hence ongoing cardiovascular disease. And this is across Australia. This particular author feels that the postnatal glucose assessment is very inconsistent and coordinated diabetes prevention programs are lacking. You could say that isolation, geographic isolation compounds this problem, but I think even in urban settings, there's a bit of a gap. Arzu, do you like to just give me your thoughts on this particular point about, or even Karen or Joel, what are your thoughts on this GDM, post-GDM testing and validation?
I guess I can jump in from a GP perspective
that's exactly what I want to know.
We often, we'll know that these women have had GDM in their pregnancies, and we'll get the, there is a register, and so we'll get the notification from the register, and provided we're that patient's ongoing GP, we annually get a reminder that they need testing, and the patient will get a reminder. But I think the difficulty is it's not such a dynamic register like the cervical screening or the bowel screening register linked to the Medicare. So as we, those women are easily lost to follow up, I think. And, I've had cases where I'm continuing to get, things to say patients due for their screening, but I know this patient's moved well out of my area. So
difficult to chase. Okay.
Yeah.
There's an interesting analogy you make with the bowel screening and cervical screening. I think somewhere if policy makers decide that that's the way to go ahead or go about increasing its testing will be good.
Yeah, and I think Inez has got a couple of thoughts as well. Inez, do you want to pop in?
I'd agree. I don't think we would know how many are done because it's not linked to an MBS item number. However, with the register and the fact that actually most women do go back to their GPs very frequently for that sort of 6 to 12 months after with their first baby. So the evidence in Australia is that for your firstborn, you actually see your GP 11 times with your baby for your first time baby, and it drops down to something like 7 for your second baby. So often women come in. GPs tend to have very good register and recall systems too that work well, but I would say my experience is that most women come back to normal levels unless they have diabetes in pregnancy as opposed to gestational diabetes.
Sure.
And the thing is that many women actually say, can I please not have the GTT because I just don't have the time. And I think that often you sort of end up with a HbA1c and fasting blood glucose. And certainly the evidence-based guidelines from the RACGP suggest that after the first one, after a GTT at 6 to 8 weeks, for every 2 to 3 years, you should be able to do a HbA1c and fasting blood glucose rather than a full GTT.
Sure. Look, I agree. I make it a point at when it gets to about the 36, 35, 34 week mark, and if things are going swimmingly well, unless it's going badly, in which case I'll be seeing them right up possibly until the end. I will make sure that I tell the registrars and obviously myself and all of us make an effort to give the postpartum GTT form to the person, make sure that the correct GP details that they are linked to is filled in, and say, look, you need to go and see them a week later to discuss results. But this is the issue is we don't get the rates of how well that's completed, and usually only when we see them the next time around. And if it's done, and that's the other issue, that I actually like to have it done using my provider number so that it's kind of linked to me. I can access it. If it's done in private pathology outside of the hospital, it will be somehow sent back to me. Whereas if it's done at the Northern, it's there for everyone to see at the next visit. All right, shall we move on to the
just Suresh, on that point from the obstetrics, and yes, when it's GDM on diet control, I know the endocrine team does not get involved. However, when we send a discharge summary from the hospital, it does usually say that the patient needs a 6 weeks GTT, but I think it's multifactorial, driven by patient as well, whether they have regular GP that they're going to go to, and the discharge summaries go to the same person as well. So I think it's like both ends, like it's patient driven as well sometimes.
And it's funny that none of you have mentioned having a new baby. Your priorities, of course, are widely different.
Suresh, I've just got a couple of questions.
Sure. Might as well address them now. Okay.
Yeah. So can you please outline the optimal regime for follow-up of specific GT tests? So timing?
Yeah, but I essentially, apart from COVID times when we pushed it out as a kind of a Queensland-based general directive to even up to 6 months post-baby to do that, or do even a HbA1c and a fasting glucose, I strictly follow the 6 week mark, and I don't budge from that unless there's a specific reason. And as I said before, I take the trouble to make sure that that you ask the person, is this the doctor who's on the hospital system? Is that the person you're seeing now? Right there, provide a number and address if I don't have one, and then make sure that they written clearly, to catch up with them a week later to discuss results. That's my teaching, and in fact, most of the staff that are there have been registrars at the Northern, so they all hopefully follow what was imparted to me and then me to them. So that's our policy at the Northern. But remember, again, Joe, the people that I see might only be 20% of the people who have gestation diabetes that are on insulin. So what Arzu is talking about is the other diet control one that we don't see. It's the nursing staff, but they also will make it a point at some stage at their last consult to emphasize to them to get it. But of course, they don't write PAT forms, and then it kind of is left to the antenatal, the obstetric unit doctors to provide one on discharge.
Right, thank you. And another question, rather than the GTT, what do you think about doing a fasting blood glucose and a hemoglobin A1C at that 6-week check, or is that more suitable for a sort of ongoing follow-up?
That's in theory that is a second option, better than nothing. And I'll give you an example of how things can change, which within the 2 cases that I have. So I think if you follow guidelines, I think the OGTT is what you're testing is insulin resistance, not so much fasting dysglycemia. So the stress of the pregnancy, which hopefully has come to an end, but doesn't necessarily mean that their first phase response may be perfect, but the second phase insulin response is not. And that's what we're trying to find out. So you're assuming that with the fasting and an A1C, remember, they could have lost blood, they may have had a transfusion, they might be anemic. So the HbA1c is going to be, for me, in my endocrine hat, wearing my endocrine hat, not as reliable postpartum in the vast majority. If you want to add that as a factor into saying it's not the best test, but better than nothing.
Great, thank you.
And just a quick reminder to everyone, just make sure you're putting your questions in the Q&A, not the chat, please. We will grab them, but we're not looking in the chat for questions. Thanks.
Okay, in the interest of time, I'm going to speed along a tiny bit. This is this landmark study that I said made the difference in how we change things. It came out in 2008, and given I'd started at the Northern not that long ago, it kind of changed the way we did things at the Northern Hospital, and also the reason for it is the demographic that we deal with. So essentially the HARPO study, which is what I'm going to call it as, was essentially done to clarify risk of adverse outcomes associated with varying degrees of maternal glucose dysglycemia or intolerance, if you like, which is clearly not overt diabetes. There were 25,000 people, women, 15 centers, 9 countries from 2000 to 2006. And they all underwent a standard 24 to 32 week OGTT with 75 grams. And they wanted to clarify associations of maternal blood glucose less than those diagnostic of diabetes with the perinatal outcomes. Now, the data remained blinded if it fell between the not clearly diabetic range, i.e. was between 5.8 and 11. And of course, if they had hypoglycemia, they were taken out of the particular pool. So the primary outcomes, and this is what I was alluding to before, where the New Zealand and the US data didn't quite show, but then the New Zealand data subsequently did, was birth weight above the 90th centile for age, for gestational age, primary C-section rates, clinically diagnosed neonatal hypoglycemia, which is a reflection of maternal hyperinsulinemia, cord blood serum C-peptide level, which again is going along the same lines of high serum endogenous insulin production above the 90th centile for reference. The secondary outcomes were delivery before 37 weeks of gestation, shoulder dystocia or birth injury, need for neonatal intensive care, hyperbilirubinemia, and preeclampsia. I think I'm going to skip this essentially because of time, but I already said they were unblinded if the 2R was diagnostic or the fasting sugar was greater than 7.0, indicating type 2 diabetes or early pregnancy diabetes. The otherwise women, caregivers, and the staff of the HARPO study were unaware of the glucose values. the overview of the study was that in this large multinational study, glucose levels that were increased during pregnancy but below levels diagnostic of diabetes were significantly associated with an increased risk of birth weight above 90th centile, C-peptide level 0 primary outcomes above the 90th centile, as well as other adverse pregnancy outcomes. And at that stage, they wrote that the results indicated the need to reconsider the current thresholds for diagnosing and managing dysglycemia, which of course we now do. This is just a chart to show you the varying levels, so they really were strict, and which is why when I take time to explain to the women that in gestation diabetes, the targets that we are aiming for are very, very strict and stringent and very narrow, as opposed to the type 2 non-pregnant state, whereas you go from 4.2 down to up 5.6 in the fasting, 5.9 to 11 in the 1 hour, and then 2 hours 7 or 5.1 to 10. This is just a reflection that no matter which parameter you look at, 90th centile, primary C-section rates, clinical neonatal hypoglycemia, and cord blood serum C-peptide levels, all of them were increased in all 3 arms of the test, which is fasting in blue triangles, the yellow square for 1 hour, and the orange or red triangle in the 2 hours. I've just marked the shoulder dystocia and preeclampsia in this where the odds ratio were more than 1, which of course is significant. So the analysis of this particular data was aimed to determine whether the threshold levels of maternal glucose for fasting 1 hour, 2 hour could be identified for any of the negative outcomes. And then, as you saw before, each of the primary outcomes was associated with high maternal glucose. And the important part of this, and this is why the range is very narrow, is this was a continuous and graded manner. It didn't have any inflection points, and therefore it didn't allow us to say above, there was a particular level above which it was really bad. And therefore the narrowing of the treatment targets, if you like, were put in place. So as I already said, each of the primary outcomes were associated with a higher maternal glucose. Association was in a continuous and graded manner. No inflection points were found, and this precludes identification of threshold levels above which the adverse outcomes rose. Secondary outcomes, all 3, once again, were significantly associated with greater than or even 1 elevated glucose level, and that's a pretty significant statement. The important points are that they thought that because it went across so many countries and so many different medical centers, they could apply the data to a global audience. The association was seen through glucose level below those of diabetes, and therefore the need to have new targets was raised. The limitations were that they did not have data on nutritional status, gestational weight gain, fetal growth, and other perinatal outcomes. The confounders such as previous GDM, maternal BMI, previous macrosomia may have influenced clinical decisions such as the choice of route of delivery. And because of the observational design of the study, they couldn't conclude that maternal glycemia is causally related. However, such a relationship was plausible. And I can tell you that this kind of study will not be allowed to be done anymore. So we have to use those inflection points to say that those narrow targets are what we need to aim for. I think I'll skip this. And essentially the bold points at the bottom are results can be generalized to develop outcome-based criteria for classifying glucose metabolism and pregnancy that was applied worldwide. And I think that's where we are. There might be a few like 5.3 versus 5.4 in individual health networks, which of course we cannot overcome, but essentially the broad principles have been accepted. So this is where we are at the moment. 5.1 and above, 10.0 and above, 8.5 and above are gestational diabetes, and that was adopted by the ADIPS, our council in 2013. So this is where we go into the IAD-PSG criteria. They suggest that at the first prenatal visit, all or high-risk women undergo testing based on local circumstances for fasting plasma glucose, HbA1c, or random. And I think the point that Joe or one of you all made about doing the HbA1c later, that particular dilution, hemodilution factor doesn't arise unless the people have thalassemia, anemia, or some other hemoglobinopathy, then the HbA1c is valid, and then the random plasma glucose. And then, of course, over diabetes is the same, 7.5, 7.0 and above for fasting, random above 11, and a 6.5 above 6.5% for a HbA1c. These you basically treat as overt diabetes discovered in pregnancy and manage them. If testing is not diagnostic, fasting plasma glucose between 5 and 7 is between 5 and 7. GDM should be diagnosed, and that's the separate pathway that they follow. If it's less than 5.1, patient should be tested for GDM. So in other words, an early test is negative, then you do an OGTT at the 24 to 28 week mark was the recommendation. They couldn't, on the basis of what evidence they had, suggest there was a benefit of generalized testing to diagnose and treat GDM before the usual window. But I think where we work, the ethnicity and the clientele that we deal with really warrants an early testing to be almost mandatory. I don't know whether Arzu knows, we've come up with a slight change in the way we do things, and I'll come back to that later, in that we used to do fasting OGTT just on ethnicity alone, and I'll come back to that later. Now we're kind of thinking about ethnicity plus one other risk factor will be the trigger for an early OGTT, but I'll come back to that in a minute. So we are now at the ADIPS in Australia, which is actually what I was referring to. The last update is 2013, and I think the conference is on next weekend. The recommendations for early testing for gestational diabetes with risk factors are moderate risk factors for gestational and high risk factors. Moderate is ethnicity and Asian, Indian subcontinent, Aboriginal, Torres Strait Islander, Pacific Islander people, Maori people, Middle Eastern and non-white African people qualify, and a BMI of 25 to 35 kilograms per meter square surface area. Now, they've written that women with either ethnicity or a BMI of 25 to 35 as the only risk factor should be considered moderate risk and should be initially screened with either a random or a fasting glucose, followed by a GTT if clinically indicated. They couldn't clearly, on the basis of the evidence that they had at that stage, they say that there was any threshold for further action at that particular point in time. High risk factors are pretty clear: previous gestational diabetes, previous elevated blood glucose level indicating diabetes, maternal age of greater than 40, family history of diabetes for type 1 or type 2 in a first degree relative or a sister with gestational diabetes, BMI of 35 and greater, previous macrosomia with a baby of more than 4.5 or greater than 90th centile, PCOS, and corticosteroids and antipsychotics being the triggers. So just going back to what I was saying, at the Northern Hospital, we dictated that as a group that we would test anyone from this particular ethnicity, not specifically taking this into mind as a initial OGTT done at the 12-week mark. It was brought to our attention that we need to reconsider that, or could we reconsider that? And I think as a group, we've taken a decision to have the ethnicity plus one of the risk factor to be the trigger for an early OGTT, which still is not yet ratified, but that's what we're just discussing. I'm not sure even Arzu is aware of this. I think this is already outlined before, and the numbers are the same: 5.1, 10, and 11. Now, this is the part that we've already talked about for a few minutes at the start. It resolves postpartum. Diabetes is likely to be confirmed in the postpartum, and the hypoglycemia in pregnancy is diagnosed early, and or the degree of hypoglycemia is quite marked. And I've got a case at the end to show you that. The shared care maternity coordinator will make the appropriate hospital appointments with the diabetes team. Now, this is where, Karen, the guidelines that you sent me have this C's shared care, which I'll either let you say something about that now, or Arzu, would you like to make a point about that? I was a bit confused when I read that.
I think we thought we should have like a consensus, because as from my understanding, Joe, at Western Health, this is not indication to cease shared care, and we can still do modified shared care if a patient is GDM on diet control. We haven't come up with any particular solution yet at Northern Health, because we have got issues with a lot of FTAs and working out a proper shared care. We don't really have that many patients with shared care anyways. Do you have any comments, Joe?
So also, before you go, the point is not necessarily even needing insulin. I'm not even differentiating between diet control versus needing intervention. This is just after the diagnosis.
Yeah, that's right. Exactly.
Yeah,
so, yeah.
Yeah, I think at Western, when I've checked in, that what has been happening is that shared care has been ceased for even for somebody who's potentially diet controlled only. And I think there has been discussion over the years, and I don't know if Lynn might have more to say about that. I think you know, probably the patients we're seeing for shared care are probably more engaged with their regular GP, and I guess it's going to be something that's going to need to be, you know, as the numbers start to increase, we may need to look at how we're going to do it. And looks like she's got something to say too.
Yeah, just briefly, the decision when we actually developed the shared care guidelines, which was probably about 2 years ago with the 4 services, was that we would actually take women out of shared maternity care for the services, but then according to the service, they might put them back in. So there was basically a conscious decision of saying, is this person appropriate to still be looked after in a modified shared care environment? At the women's at the moment, once somebody has gestational diabetes, even if it's diet controlled and well controlled, they still are not suitable for modified shared care. However, we know that the outcomes for those women are very good, and it's probably just a matter of actually starting some support and communication processes, and it's something that we'll probably develop next year. But each of the services actually manage that differently.
Good. So that's what I was going to just point out, that they've got some, you know, refer chapter 3, which I've got the next slide, which I'm going to go over because we've already outlined the fact that it's not still currently. But I hope something that comes out of these kind of talks will instigate change in that. And Karen and me had a chat a few weeks ago, last week, that they're more than capable of being managed, provided I've got a few bullet points at the end to say, if resources are available, if the patients are engaged with their primary care physician, then this does not need to specifically be managed in a tertiary hospital setting. And I'd like that to be sort of maybe noted down for future discussions. All right. I'm going to skip this, and I'm just going to go into a couple of case studies which might address a couple of things. And I have on the request, I'm not sure whether it's Joe or Gillian, who's not here today, to talk a couple of lines about testing in post-bariatric surgery, but I think given Lynn's talk, will hopefully may address some of that. I'll keep that relatively brief. This doesn't necessarily pertain so much to the shared care model, but these are the kind of instances that raises even concerns in someone like me who's been doing this for a while. And this is literally now, 3rd of October. I saw this lady in an in-person review. She's 36 years of age, Sri Lankan background, 3rd pregnancy. And I met her for the first time, I think the previous week. So I'd probably seen her 13 weeks postpartum. And it was brought to my attention by the nephrologist who was looking after her for some proteinuria that was pre-existing. She was having her, and this is the good outcome that came about Arzu and everybody else about the OGTT being done. It was done actually at the Northern, and given the renal physician was following it up as part of the proteinuria management or ongoing care, came and walked into my office and said, Suresh, I've never seen a GTT this bad recently, and I agreed with him. And the additional layer of interest to the story was this lady had gestational diabetes that was diet managed throughout her pregnancy. So this was the 6-week postnatal OGTT done on the 12th of August, where the fasting level was 14, 1 hour post 23, which is pretty dangerous. And I think we also need to, when I have some time, we'll need to bring this to the attention of the testing lab. I don't know how we're going to do this. Once it is so high, there's no need to proceed with the glucose load of that lab, to that extent, given that itself is quite dangerous. But anyway, she'd gone through that. And hence now has type 2 diabetes. As part of a workup, I tested her for type 1 diabetes and it was all negative. And when she came and started testing postpartum, levels were not that high. So I started on some metformin. It took it for 3 days. She said that she couldn't even look after her baby. She was so tired, which again, I didn't quite understand. So she stopped it. But thankfully, she had at least spoken to her GP, who she obviously trusts a lot, and who advised her to take it at least once a day, which she had not done until I saw her. When I met her the week after, she brought in a week's worth of blood sugars. They were not terrible. Therefore, I re-convinced her to restart her metformin, if you like. HbA1c in September was 9.3. And this is the interesting part. In January, this was at OGTT. She just about made it in the fasting level of 5.6. We didn't have a HbA1c, of course, then. And she was completely diet controlled throughout her pregnancy. So my plan when I saw her in early October was a review in 3 months with pathology prior, and if all well, we'll discharge her back to the local doctor with the diagnosis of type 2 diabetes. So I thought this was interesting in that if the usual processes have been followed, it came to light and management was instigated. Now, God knows what would have happened if this had not happened. That's a scary thought, but it was something that I thought is worth sharing. This is probably more to do with preconceptual counseling or management, and I think this will raise a few issues. This lady is of Aboriginal background, 29 years of age. I met her first, I think, in July, and this is the last review. She's due to be seen next Monday. It's a face-to-face review. She's 29 G5P3. She was 31 weeks at that time. Diagnosed in 2022 March with type 2 diabetes on the background of previous GDM. Her BMI was 49 at 31 weeks of gestation. She was treated with dual antihypertensives and had a blood pressure which was acceptable at that stage. This is going back in March of this year. Her HbA1c was 12% for a 29-year-old, just terrible. And she had some minor non-alcoholic steatohepatosis levels on her LFTs. The rest were normal. This is her obstetric history. 2014, she had a, so going back, 8 years ago, she would have been about 21, 38-week baby, emergency C-section for failed induction. She had insulin with gestation diabetes and a 3.2 kilogram baby. I don't know the centile. 2017, again, elective C-section for a term, no gestation diabetes as per the history, which was again at the Northern. She suffered an early pregnancy miscarriage in 2018. 2019, and this is where I think the tie-in with this story is important. She had elective C-section, was being managed by us on insulin. I looked at the notes just before I wrote up her story. We had seen her at 35 weeks and meant to see her the next day, but I don't know what happened. There was no notes, and she essentially came in for delivery 3 weeks, 2.5 weeks later. And she was not on, comparatively not a whole amount of insulin. And there was no plan made, or at least evident on the notes, that an OGTT needed to be done postpartum. And I looked through both ours and a couple of other private labs, and I couldn't find it. Now, that was a question that I raised: was her OGTT done postpartum? But again, you could say 26 units. The scary part was her BMI. So that should have been, on this grounds alone, I wouldn't have been that terrified of her postpartum state, but her BMI alone should have, raised flags. So the last antenatal review on the 11th of October, she had a fetus that was greater than 90 cells. So we've kind of missed the boat a little bit here. And I think it's in large part due to the bad start that she's had. Currently, she's on nearly 20, 40, 50 plus 30, 80 units of insulin. And I restarted some metformin as a sensitizing agent. She was on aspirin, nifedipine, Aldomet, and needed some vitamin D. So this is a case of the OGTT story that we talked about before, probably not being done. I can't say that for an absolute certainty, but that's where I am at. Have you got any questions on these two patients? We've got another few more minutes to go before we finish. I've just got maybe 2 slides on testing for GDM in bariatric surgery.
I haven't got any specific questions that have come through on those cases, Suresh. So sure. Maybe do the last slides and then we'll go through the rest of the questions.
Sure.
Yeah.
Okay, this is essentially gestational diabetes. Most things are worse than if you didn't have it. And I think the only thing that was was similar was the APCA scores. I'm going to leave all this alone. We know that the mother gestational diabetes has poor outcomes in the uterine environment for the baby, who then ends up with type 2 diabetes, glucose intolerance at a higher rate, and obesity. The long-term consequences of diabetes is 1 in 5 women. I think it's a bit higher. This is a little old, 2008, and from Canada. We've already talked about the local data suggesting about 40% of the First Nations women, and maybe 25 or 30% is more like the non-Indigenous people with diabetes. The relative risk is 7.4, which is quite concerning. Now, there's a statement which I thought was a very poorly worded, but I think well-meaning. A history of GDM provides a low-cost natural screening test for future type 2 diabetes. I don't think there's anything low cost about it at all, but I think the principle of what they're trying to outline is that it's incidentally found as a predictor of future type 2 diabetes. We've already talked about this. I think all of us need to really make sure that we try our best to get the postpartum GDT done, and that would probably be the most useful concept that I could advocate for in this talk. This is what I think was asked: postpartum GDT at 6 to 12 weeks and a fasting blood glucose every test. I'd probably, depending on the ethnicity and the age, even narrow that on an annual basis, for example. That's where the current advice lies. And this is a very useful little tool that 150 minutes per week of moderate intensity physical exercise gives a massive reduction of incidence of type 2 diabetes occurring. So I'm going to literally maybe, I've got 5 more minutes to go, and I'll just maybe 2 slides and have the last few minutes to talk. There's currently no clear guidance on what to do post-bariatric surgery. And the main issue is that the preferred test, which is GTT, is quite dangerous. You have post-absorptive hypoglycemia, and the other issue is misinterpretation of these levels. You get 1 hour level misleadingly high, and then the 2 hour level misleadingly low. The 2 hour misleadingly low is due to an overshoot of their pre-surgery insulin overshoot for a paired glucose, and therefore they end up with what we call a reactive or responsive hypoglycemia, and it's pretty dangerous. Other issues of dumping syndrome can occur in women after the Roux by bypass or sleeve gastrectomy, which is done in a whole lot. So I'll just quickly go to the this is the American Gynecology Society guidelines. They suggest home glucose monitoring for several days, 1 week. They don't say when, and if it's fine, then leave it alone. They talk about capillary glucose testing from 14 to 16 weeks with continuation throughout pregnancy, which I think is a bit impractical and onerous. They talk about CGM, which we don't have access to, flash glucose monitoring, which again is a US thing, which I suppose depending on your health insurance status, you can access. And this is what they suggest to do. Again, this is US guidelines, which doesn't really relate quite well to us. So I'll just go to a local study that, sorry, how do I go back? Yeah. So this was from the MJA. So they looked at the evidence and said, currently there's no clear guidelines as to what to do. They're basing their logic on a fasting capillary blood glucose level. So the Obesity Reviews Journal in 2019 says, first trimester, treat as if they've got type 2 if you've got a HbA1c of 6.5 or a fasting plasma glucose of 7, so it's type 2 diabetes. In the second trimester, they suggest capillary blood glucose, so they'll have to have a glucometer, undergo some education, and do their profiles, or CGM, which again, I don't think is an option for us, for 1 week between 24 and 28 weeks of gestation, and the evidence for that is level 4. Repeat HbA1c if there's a personal history of diabetes. Again, evidence is level 4. I'm going to stop with this because there's only 2 more minutes, and I'd like to see if there's any more questions. Shall I stop sharing, Joe?
Yes, that's probably easiest if you're right.
Yeah.
All right, there's quite a few questions. So can you talk a bit about what sort of levels and indications as the endocrinology team or the obstetric team in the hospital would be starting insulin at?
The simple principle we follow is 3 blood glucose levels. So the way, I'll give maybe a bit of a background. So if, let's say, a lady or either in a group or an individual review after a positive OGTT has come to the attention of the allied health staff, i.e. the dietetics and the DNEs, and they then get sent off to hopefully make some changes to their diet, their lifestyle, and start testing QID, fasting, and 2 hours post meal for 3 times a day. And so in 28 readings the week after, they are seen by either the dietitians or the nurses. And between them, if they've got more than 3 readings, they bring them to the attention of one of the doctors in the clinics fairly urgently. And then we decide, without necessarily seeing them, to start them on insulin, which means that nurses have to have a teaching session. And then within a week or 2, then they're reviewed by the endocrine team, i.e. the doctor. So that's generally the approach. And therefore, it has to be anything of 5.0 and above fasting and 6.7 and above post-meal on 3 occasions in any particular random pattern. So it can be 1 fasting and 2 post-dinners or 3 post-dinners, whatever the case may be.
Great. Thank you. For the early testing, what weeks are you recommending that we should be doing it? I know in clinic we at Sunshine would normally do sort of 13 to 18 weeks.
Yeah.
For the GPs, do you have a preference?
I basically say 12 and above because of the nausea limiting the ability to probably go through an OGTT. And therefore, anything early is, I think, a fasting glucose and HbA1c is fine. And if we then see them at 12 weeks onwards, we would advocate if their risk factors are high. As I said before, we were doing it on everybody in the ethnic group that if it ticks that box, but we might change track and go ethnicity plus 1 other risk factor too.
Great, thanks. And I've got somebody who's got a case of a patient who had a fasting sugar of 5.1 on their routine antenatal testing. Should they still go and do an oral glucose tolerance test?
It's a tough one. In reality, if it's a venous glucose done at a lab, you have to rely on it even more so than a finger prick testing. So I'd rely on that quite a bit. If you want to take a little bit of a kind approach, you could say that alone is good. You can get them to start testing and make some adjustments and see what happens. If you want to be absolutely sure, and if they're beyond the 12, 13 week mark, plus they've got other risk factors, I would discuss the options of doing a GTT with them. It's just a question of, working out what that particular person needs. So that's what I would do. I would either say, start testing and see how things go. If let's say the dietitian comes or the antenatal obstetrician comes and says, I've got this 5.1, what do I do? This is what I would say. Get them to test week or 2 and see how things go. Otherwise, if you're in doubt, just do an OGTT. We're looking at second phase insulin response, which I said before. So it's hard. It's a tricky one.
And any role for CGM in these women?
Where do you get them from? Type 1's easy. It's a whole separate story. I don't know. I don't have any of our nurses. They may have 1 or 2 on loan from the suppliers before, so we could use them in situations where we thought there was some discrepancy between what's going on and what's clinically happening. So short answer, not for wide use. It's going to be very selective person that we'll pick it for.
Okay, thank you. And why would you start somebody on metformin rather than insulin?
As I said before, it'll purely be on patient refusing, I suppose, is the word. So the only reason I use insulin later on, like the other lady, was once I get past 30, 40, 50 units to use it as a sensitizer, type 1 even, I'm happy to use metformin. So I'm a big proponent of metformin, but as a secondary role. And of course, you have not that many, to be fair, who completely say, no, I'm happy with tablets when you explain what we do in Melbourne, in Victoria. So if they know it and don't want to, then there's not much we can do. We just go with metformin.
Okay, thank you. What's your advice for the prenatal management of a 38-year-old woman with type 2 diabetes, well controlled on metformin? Any need for change of her medications?
No, if they've got their target of A1C of about 7, hovering around 7.2%, I think you can go down a whole pathway of type 2 diabetes, whether you want to look into their cardiovascular risk factors, renal risk factors, BMI, etc., and then go down the pathway of SGLT2 inhibitor if they're not trying to conceive fairly soon, or GLP-1 analog if it's available, which is now in shortage, or other options. But effectively, if you've got metformin and doing its job, no need to change at that point in time.
Great, thank you. And another question about if you've got a patient who's needed insulin through a pregnancy, when does it stop postpartum?
Literally at delivery. So they'll have their last dose. For example, if they're coming for an induction of labor at 2 o'clock in the afternoon, if they're just on basal insulin at night, the last dose will be the previous evening or the previous night, and they rock up. If they're on TDS, they will do whatever they do at home. And if they're arriving at 2 o'clock, they'll have their lunch and their insulin before that and rock up, and the rest is done at the hospital. If it's a primate, having induction of and rupture of membranes at about, they usually do it in the morning. So she'll have a 3rd dose of insulin in the night. She'll have a nighttime dose on a basal bolus regimen. And morning, they can still, if they're going to have breakfast, they can have their morning insulin. So it's a very situational, personal, tailoring to the particular individual. And you go with that. So it's right up to the end. And if they doing everything normal at home, they can continue whatever insulin regimen they're on at home till they arrive.
Great, thank you. And then I think there's just a couple of comments about GPs starting patients on medication. I think from the hospital's point of view, it's a preference would be that it was left to the hospital teams.
No. I'm going to differ. This is exactly the point of the talk. If in fact, I had a slide for that, but my point is, if you've got resources of a patient who trusts you, if you've got the resources to a diabetes nurse and a dietitian, not necessarily on site, who can do the initial management of teaching the dietary modifications needed, the testing is done. And if the blood glucose levels, as I said, you can allow 2 to 3 excursions above the targets on a given week. You really have to, if you are confident, I don't see any reason why, depending on the pattern, an insulin can be started. I have no problem with that. I'm not sure whether Arju will completely agree with me, but I think the more you get comfortable doing it, and remember, we also started doing this at some stage just as the residence registrars, and then we go along. So you'll get some experience with it only if you start. And I think most likely it'll be a basal insulin that's needed. It'll usually be the fasting that's at issue. A nighttime optician Lantus equivalent now is a very sensible choice. The older style obstetrician used to use Protophane only just because that was all that was available in those days. Insulin for dinner, if just the post-dinner glucose is elevated, or a fasting, if the fasting is elevated, you pick a basal insulin. And if you've done the job, and once you get to the point where you're not comfortable managing it further, then the referral can be made. But I have absolutely no harm, because we send letters all the time to doctors, so they kind of know what we do. And I think if it's reciprocated, we're very happy with that. I don't know whether Arju would agree.
I think I've got some reservation, and I guess
sure you would.
Glenn will agree with me on this too. So I think it's not only about the managing, it's the counseling and the follow-up which comes with it for obstetric patients. And then like a closer follow-up in the hospital setting with a multidisciplinary team. So so that's why I think if you need to start on insulin, it's better to send a referral, and an urgent referral from the hospital.
Also, but they can start, is my point.
As long as they're comfortable with, yes.
Well, but you're not going to get comfortable if you don't do it. Sorry, I'm going to stop. I think Glenn's
I think that's right.
Glenn's laughing. All right. Thank you very much, Suresh. It was a wonderful talk and very informative. So, and lots of food for thought for us as we review our guidelines with this tsunami of diabetic patients and how we're going to manage.
Good word. Take one word. Thank you.
Thanks. All right. So, so I'll hand over to Glenn now, who's going to continue the talk on the care of the pregnant patient above and below healthy weight. Thanks, Glenn.
Beautiful. Good evening, everyone. Just checking you've got slides on screen and that you're hearing me.
Yes.
Beautiful. Thanks very much. All right. So good evening, everyone. Thanks very much for the invite to come and talk to you about my favourite subject in the world, at least about above healthy weight issues in pregnancy. I'm not sure I know that much about below, but I will touch on that in my talk. I'd like to start off by respectfully acknowledging the traditional custodians of the land on which we're all meeting across various areas tonight, and pay my respects to elders past, present and emerging. Now, I am an obstetrician and gynecologist. I have a particular interest in extreme obesity in pregnancy. And I want to be really clear as I go through my talk, and it actually is a nice segue from diabetes. One of the biggest problems with diabetes is that there's significant confusion over terminology. Whereas we have just discussed, and Suresh has very nicely presented some data to suggest, and I saw one of the questions that came up raise this issue about really, is gestational diabetes as big a deal as we might imagine it is? And that's a debate that will continue. That is not the same as type 1 diabetes. And conceptually people get that, but actually there's a lot of confusion about type 2 diabetes. Type 2 diabetes is an absolute disaster in pregnancy if it's not carefully managed. And so it's really important contextually that you take the previous conversation was about GDM, not about pre-existing diabetes. Similarly, in my talk as I go through, I'm not going to be spending a lot of time talking about my area of clinical practice, which is essentially women with extreme BMI 50 plus, and the complexities in pregnancy. I will touch a bit on that, but I don't want the impression that as we go through the complications and what we need to do to manage, that this is about that end of the spectrum. And a bit like diabetes, gestational diabetes is actually a construct. It isn't a line in the sand where you suddenly develop a problem, and if your blood sugar is 1.1 of a unit better, you don't have a problem. It's a continuum, a bit like BMI. It's a continuum, and there are risks as you move up that continuum in terms of your weight. So just as a brief outline, I'm going to talk a little bit about world data, Australian data, and I'm actually going to present a little bit about what we're facing in the western suburbs, because some of our data are fairly amazing. I'm going to talk mostly through my talk about obesity in pregnancy. And I really, if there's one take-home message, and if you've lost the will to live halfway through my talk, please take away the message that you absolutely have to be aware of the risk of stillbirth associated with increasing BMI. And it's really important that all of your management in pregnancy, takes that into account. We'll talk a little bit about planning for pregnancy and what you need to do early. And I really want to talk to you about what I see as silos at the moment, and a significant separation between what happens in primary care and then what happens at a hospital, and how we might be able to sort of join the same sort of approach to women living with higher BMIs. I'm going to talk a little bit about growth assessment, planning for birth and some postnatal care, but that'll be a small part. I will then talk a little bit about what it means about being underweight in pregnancy. And because of the increasing presentations of women who have had a bariatric surgery prior to pregnancy, I will talk a little bit about that as well. Okay, so this won't necessarily be too much of a surprise. So these are very up-to-date data from July of this year, showing the percentage of women who birthed in Australia recently and their BMI. And probably just to really highlight what we're dealing with at the moment, and Suresh touched on this. If I've just drawn that red line there at the 50% mark, you can see that there's a lot of women and a lot of states where more than 50% of their antenatal or the women that they care for in pregnancy are either overweight or obese. In terms of change over time, it's interesting to see, and you can see it's broken down by different states here, that Queensland has always had a relatively high percentage of women who are underweight. So we're looking at a BMI. It is variously diagnosed, but for the purpose of my talk, we'll be looking at a BMI below 18.5. And you see, and not again a surprise, it has slowly decreased over time. And then noting that the percentages here are different on the two sides, the rates of obesity you can see have slowly gone up over time. And I've only just noticed that the feet on the scale in the top right corner are men's feet, which is probably a bit silly. In terms of international comparisons, we're not doing as badly as some countries, but we're certainly up there as a population that has some of the highest obesity rates in the world. Just a little bit about local data. So Joan Kerner at Sunshine Hospital is a massive service now. In fact, it's the second busiest maternity service in Australia. And we have about 27% of the women we care for are living with a BMI in the obese category, so 30 and over. We have about 7% of our women actually have a BMI of 40 and over. You can see on the right-hand side how those levels have gone up in terms of percentage over time. And then just down in the bottom right-hand corner, and note these numbers, not percentages, for the BMI over 50, that's rising. And that's partly because we're a referral centre now, and we pick up women with very high BMI across the state and interstate. Also just wanted to sort of contextualise something else for you. It's really important when you're thinking about outcomes for pregnancy at different services that you actually take into account case mix. And there are some amazing differences around the country. And if I just show you some WH Women's Hospitals Australasia data, each of these points here with a number, are hospitals with, and you can see along the bottom their birth rate. These are coded data, but I'm going to be naughty and break some of the codes. That's Joan Kerner Women's and Children's, so the western suburbs of Melbourne. So as I said before, we have about 7% of our women have a BMI over 40. There are some services, and these do include some New Zealand hospitals. And you can see that we're sort of up there. It's an extraordinary difference between what we look after and what the women's looking after in terms of high BMI. And I'll explain shortly why that is so important in terms of what you manage from an acuity point of view as a service. And then on the right-hand side, you can see, and again, Suresh touched on this. So we have around about 25% of our women now are diagnosed with gestational diabetes. Or 25% have diabetes in pregnancy. The vast majority is gestational. We have about a 1% type 2 diabetes rate. Okay, so what does it matter? Is it the same as diabetes, and we could argue about it, or actually is there some really good evidence that being overweight and obese is dangerous in pregnancy? So I want you to imagine a pregnancy complication. Then I want you to say to yourself, I wonder if this pregnancy complication is more likely if you're obese or overweight. And other than one, I will highlight in a moment, the answer to your question is almost certainly yes. So almost every poor outcome in pregnancy is associated with rising BMI. The one that might surprise you, which is a source of some debate, but has been repeatedly shown, is that obstetric anal sphincter injury does not appear to be. It actually appears to be slightly protective. And given that we know macrosomia is more likely, it's a kind of an interesting discussion point. But essentially, everything you can think of is associated with rising BMI. And I'm just going to really stress this point. So if you just look on the bottom left-hand of this slide, you've got the percentage of gestational diabetes and the columns. You can see the key is on the right-hand side. That's standard weight, overweight, class 1, class 2, and class 3 obesity. So 30 to 35, 35 to 40, and over 40. And as we go along, you can see a very impressive effect on your chance of being diagnosed with a hypertensive disorder in pregnancy. I'll come back to cesarean in a moment. Chance of macrosomia, neonatal intensive care unit admission, hypoglycemia, and that's dangerous postnatally, and then early postnatal infection. And perhaps to really sort of stress how basic an issue BMI is in pregnancy, this is what happens to your chance of a cesarean. So these are statewide data, and it doesn't matter where you look. If you look at nulliparous women in their first pregnancy, you can directly predict, you can accurately predict their chance of a cesarean, whether they're induced or not, on the basis of their BMI. And probably worth noting there, as we'll talk a little bit about being underweight, that it's actually a protective factor for not giving birth by cesarean. I haven't got time to go into the mechanisms of what lies behind that, but as everybody knows, if you read the Herald Sun, obstetricians are these terrible people that keep doing unnecessary cesareans, and the cesarean section rates keep going up. It is almost certain that the reason the cesarean section rate is going up is because obesity is going up, and it's often not taken into account in analyses. Because it's often not quite believed what a powerful effect it is. And I just sort of glossed over it, sorry, on the previous slide. You can see here, it's unplanned cesarean. It's a very, very dramatic effect. Okay, and I've mentioned this once before, I'm going to mention it again. If you take home any message around weight implications in pregnancy, it's that it dramatically changes your chance of having a stillbirth. Stillbirth is much more common than the lay public would imagine. You're looking at in the region of a 1% chance. If you get to 20 weeks pregnant, you've got a 1% chance or thereabout that you will not take home a live baby. And you can see this, that's one of my favorite graphs I've ever seen in medicine on the left-hand side here. Don't worry too much about what the risk of stillbirth per 1,000 ongoing pregnancy is, but just look at the incredible separation. And so what this separation in these lines is telling us is it's a continuous effect, BMI, as I've mentioned before. The reason I run the Diamond Clinic is demonstrated because of this red line here, what happens in terms of stillbirth risk. But at every point in pregnancy, whatever your BMI is, if your next door neighbour has a BMI 1 unit lower than yours, her risk of a stillbirth is lower. And so if you conceptualize that every woman has a 1% chance of experiencing a stillbirth, then you could say that anybody with a BMI class 1 has a 70% higher risk of experiencing that, 100% higher risk, 150% higher risk, etc. as you go up the BMI classes. Actually, sorry, just before I go on, the reason you may be wondering, it is multifactorial, but a large amount of it relates to the fact that a significant part of what we do in antenatal care is try to detect the small for dates or growth restricted baby. And that becomes harder and harder and harder as your BMI goes up. And part of the problem is that ultrasounds get lower, get less and less accurate as your BMI goes up. So we're between a devil and a hard place in terms of being able to predict, detect growth restriction in pregnancy. And that translates into missing growth restriction, which probably is the main reason why it translates into this stillbirth risk. It's not the whole story, but it's a good starting point. Okay, so what do we do about it? Hopefully I've convinced you that it's important, but what are we going to do to try and mitigate these risks? So this is challenging, and I've been talking about obesity now for 14 years in pregnancy, and there's a lot that I'm still saying actually we're a little bit unsure. There's certainly plenty of guidance available, but this study quite acutely identified the fact that international guidance is pretty variable, and that's because we're still accruing a lot of the randomized control data. I'm not particularly going to go through this. It was just to say that across these Australian, American, Canadian, and UK guidelines, there's quite a lot of differences. A bit like gestational diabetes management, part of what that's telling us is if I saw a lot of the questions, you know, what about this situation? What about that situation? And Suresh, and I completely agree with him, a lot of the time you go, actually, it's just not that clear. So for a lot of the obesity management, there are things that are not that clear. But rather than feeling depressed and scratching your head, there is guidance available. So there's an obesity during pregnancy guideline available on the Safer Care Victoria website. And I'm going to talk you through probably some of the concepts of what you should be thinking about when you look after a woman who's overweight or obese. most importantly, and if my most important message of the night is stillbirth risk, my second important message is that as general practitioners, you are absolutely central to us at least attempting to mitigate the risks for these women, because a lot of the problems are not reducible. A lot of the risks are not reducible through pregnancy, and so you need to be doing things before pregnancy, and that's clearly the area of expertise of yourselves. And one of the things that I see, even in the extreme ends, where I look after women BMI 50, 60, 70, 80, and I always ask them whether anyone's ever had a conversation with them about risks in pregnancy, and genuinely I've never had an answer that says yes. Now that may be not quite correct, but it certainly, and there are research studies out there to confirm that there is a bit of a gap. And given what I've shown you, that the implications of higher weight in pregnancy are a continuum, then women who are overweight or have a BMI of 30, 31, 35, etc., should all be part of the planning and conversation around managing and mitigating those risks. And I think that's for general practice to be able to do that. Actually, I meant to add it into one of my slides, and I could put it in the chat at the end. And there is actually, by complete coincidence, I have to get an email today about a course coming up to discuss weight management in general, because some people find it a hard conversation. And if somebody reminds me, I'll stick the link into the chat. The other thing, and we'll talk about weight gain targets in a moment. Weight gain targets are really challenging because we're still not sure how much difference they make, and I'll go through that. But they don't appear to do any harm. And so if indeed we do eventually find that they are helpful, there's lots of women who've gained far above the ideal weight prior to ever getting to a hospital appointment. And so it should be part of early counselling conversations for any woman. That there are guidelines around how much weight you should be putting on. And similarly, exercise. Every pregnant woman, irrespective of being overweight or obese, should be advised to exercise regularly through pregnancy. At least 4 times a week, 30 minutes. I would actually be telling pregnant women to exercise every day if you possibly can, because if you advise 7 times a week, it'll happen 4 times a week, and if you advise 4 times a week, it may not happen at all. And many women with high BMI have not had a screen for diabetes pre-pregnancy, and for many we seem to miss the boat about starting aspirin and calcium, and I'll talk a bit more about that in a moment. And I think this is what we're dealing with. The ideal would be that we're all singing from the same song sheet. We've all got the same impression of risk in our minds. We're slightly anxious about a woman with a BMI of 27 than we would be if she had a BMI of 23, etc., etc. And we all need to be doing the same things and commencing the same conversations, because it's actually really difficult when women come along. And if we are looking at class 2, class 3 obesity, and that conversation hasn't been previously had, it makes the counselling harder. Whereas if we're all talking about the risks and explaining them and pointing them out in a careful way, because the challenge with talking about risks in pregnancy is that it can generate anxiety. But if any of you have ever heard or gone to a forum on stillbirth and heard women who've experienced a stillbirth implore clinicians to talk about risk, it's a really, really powerful message. All right. So with that in mind, and trying to sort of look at things a little bit differently going forward, I think part of what we need to move to is this concept of the inverted pyramid. So the traditional model is that you may have some care in private practice, and then you get referred to a hospital, and you're seen not very often to begin with, and then we get really worried about you later on because we want to try and pick up preeclampsia and growth restriction. But there is a lot of support at the moment around actually flipping that round and doing a lot more early on. And that includes pre-pregnancy and then early pregnancy, very, very regular visits. And that applies to all sorts of risks in pregnancy, but this topic is around weight and weight management. It's to get that advice on board and set women up for a successful pregnancy. So rather than putting your resources into going hunting for problems later, put your resources into limiting the chance of those problems early on. Okay, so a little bit in more detail about then what can you do? So have the conversation about the risks. And that does apply to low weight as well. We'll come back to that. I'm talking about obesity and overweight at the moment. Because the most important advice you can give is to talk to women about actually, as much as possible, achieving a healthy weight prior to pregnancy, and then limiting early weight gain as much as you possibly can. And you know much better than I do about how to have this conversation with women, but it needs to be had. There is a role for bariatric surgery, and I'll talk about that, but weight loss medications are still pretty much seen as a no-no. That there's potential in the pipeline, but essentially they're currently a no-no. Even if you can't improve weight pre-pregnancy, any reduction clearly brings you down that risk curve. And also it begins your conversation about limiting weight gain. And you can be having the conversation. So women with higher BMI, and there's various thresholds, would be recommending high dose folic acid. Remember, as part of your pre-pregnancy, you're always talking about vitamin supplementation in general. We've mentioned diabetes screening, obviously, and of course, smoking advice. And then what do you do sort of in early pregnancy? So given that some of the problems that are experienced for women with high BMI and in fact with low BMI who are underweight, there are various levels of risk of preterm birth, be that spontaneous or iatrogenic. And so a dating scan is really, really useful because at the limits of viability, days matter. And so getting some accurate dating is important. And obviously for some of these women, they're going to have other problems, so we'd like to see them early. And if they haven't had a previous screen, then you need to screen early. And that there was a little bit of chat, and I think Suresh might have touched on it. There are some concerns around how early in pregnancy you do the screening. So at Western at the moment, we are repeating screens, even if it comes back with a very abnormal result in the first trimester. And I've been a bit cynical about that, not believing that the glucose intolerance could disappear, but actually I've been proven wrong, it does. So we do repeat the screening. It's important to know that if you're going to counsel women about screening for aneuploidy, and you're going to do non-invasive prenatal screening, the risk of you getting a result that you can't interpret, or a so-called no-call, goes up with each class of obesity. And that can be really challenging, and it's an important part of counselling. I think it would sit nicely with your pre-pregnancy counselling, because there's something very tangible about not being able to give you an answer to a really important question about Down syndrome screening, because you're currently above a healthy weight. We do recommend, as women go up the BMI scale, that they have an anomaly scan done by a service that is experienced and skilled at undertaking anomaly scanning. There is an association with an increased risk of congenital abnormalities. That's multifactorial, but part of it is a failure to detect. And so when you look at data of women born with a child with a congenital abnormality, part of it's because they just couldn't see it on the ultrasound scan. Calcium and aspirin, I'm just going to stress, because there is some misunderstanding about this. I'd be asking yourself the question in early pregnancy, is there a reason why I shouldn't start someone on calcium and aspirin, rather than is there a reason why I should start someone on calcium and aspirin? Very good evidence for a reduction in preeclampsia risk. Preeclampsia is one of the major problems associated with rising maternal weight. It is really important to note that the calcium dose is much higher than most people appreciate. All of the studies suggest that you need between 1,500 and 2,000 milligrams of elemental calcium, and most of the preparations we use only have 600 milligrams. So to get yourself up into the 1,500 to 2,000 milligram range, you need to be giving the calcium 3 times a day. There are some compliance challenges with that. If women find the compliance challenging, I tell them to take it all at the same time. I've heard various reports that that works or makes people feel a bit unpleasant. And you want to start that as early as possible, and you can absolutely start that in the first trimester. And it's a very useful medication. And it is worth noting that I have seen medical legal cases where part of the story has been an accusation or an allegation of a failure to commence preeclampsia reducing medication. And similarly, aspirin, it is absolutely safe in pregnancy in low dose. The biggest problem with aspirin in pregnancy is that if a woman goes to buy the aspirin at the pharmacy will tell her it's dangerous in pregnancy. So we try and provide written information about that. Jo.
There's a question about the evidence, what evidence there is for the calcium supplementation in pregnancy.
Yeah, so no, it's good evidence. It's level 1 evidence, randomized control studies. I can't remember the exact risk reduction, but it's in the region of 0.7, so it's a 30% reduction or thereabouts. If somebody wants to, it's fairly easy. It's actually it's in the Cochrane database. It's very, very good evidence. Yeah.
Thank you.
No problem. And the aspirin ideally should be taken at night. It's a little bit unclear why it's beneficial at night. It may be that compliance is better for medications taken at night. There's an ongoing debate about whether 100 or 150 milligrams is the correct dose. And one of the problems with 150 milligrams is that it means breaking a 300. And I have a little bit of anxiety about that, communicating that message sometimes, but also whatever you put in front of a patient about medication that puts another step in them completing the task of compliance, the compliance will go down. And so I'll often recommend 100 milligrams, and the evidence for a beneficial difference is very, very weak. Jo.
Now, in the issue about what BMI would you start folic acid, the higher dose folic acid at?
Yeah, I purposely didn't put it in. 35, you're going to make me commit myself.
Yeah, right.
Just for everyone's benefit, the reason I'm smiling is because you going back to those guideline issues that I mentioned, it's different in every guideline you'll read. To a certain extent, whenever I'm dealing with a clinical issue where nobody can make their mind up, I take that as fairly reassuring that I probably can't get it too wrong. And so I know there's this ongoing debate about high dose folic acid. Anything that's been debated for that long, and you've got a 0.01 absolute risk increase in something, tells me it's probably not that bad. And so I wouldn't be overly anxious about it. Sorry, Jo, I think you had another question.
I had another question. It's about the low dose aspirin and calcium. So you would use that in women who are not only obese, but who've got other risk factors for preeclampsia as well.
So as I said, I'd be thinking of reasons why, talk yourself out of giving calcium and aspirin rather than talk yourself in. It's incredibly safe. There's good evidence behind it. And a large percentage of the population, particularly if they're in their first pregnancy, have a risk of preeclampsia for whatever reason.
So maybe everyone, almost.
Yeah, I'm not going to go there because learned bodies don't want to go there quite yet. The reason it hasn't been taken on as a general recommendation is because there is still a little bit of concern about the effects of non-steroidals in first trimester. And there's some concern that if you recommend something to be taken in pregnancy, will women actually take it after the first trimester? And I think that's what sits behind some of the debate in this space.
Okay. And continue the aspirin until 36 weeks.
Yeah.
And then calcium all the way through.
Yeah, I mean, yeah, I tend to, it's easier to keep things simple. So I tend to say stop them both at 36 weeks. Just from an easy messaging point of view.
Okay, great, thank you.
And just to reassure anyone, if you happen to go into birth early and you've been on aspirin, the evidence is it makes absolutely no difference at all to significant maternal morbidity if you happen to deliver early. Okay, so I'm going to talk a little bit about weight targets because there's some really interesting new information in this space, which is beginning to creep its way into some sort of peak body guidelines. So you might be aware of the recommendations on the left-hand side here. These guidelines were not evidence-based. They were based on retrospective, they weren't based on any randomized controlled trial data. They were based on retrospective data, but actually a lot of the data was actually imputed into computer models. And because they couldn't separate out the different obesity classes, which was largely a coding issue in the US, they lumped women with all living with all classes of obesity into this same 5 to 9 kilo weight gain. There is a little bit of more clarity about this now, and I think this is worth taking on. So I've put the reference at the bottom there. It's an impressive study. I meant to put I did, yeah. So it's 200,000 women it's based on, and it's looking at a constellation of outcomes and what is the best weight change depending on your starting weight in pregnancy to reduce your risk of having those various outcomes. And they included development of gestational diabetes, preeclampsia, stillbirth, etc. So they're looking at sort of fairly hard endpoints. I'm just going to talk about these one by one. So underweight women, essentially found pretty much the same thing, the total weight gain through pregnancy around about 14 to 16 kilos. For women who are in a healthy weight range, and I'd encourage everybody to use that terminology and not normal weight, again, pretty similar, 10 to below 18. If you are overweight, this is where things start going down. So they found the optimal weight gain was less than 16 kilos and more than 2 kilos. And I hope that's clear. That's not a minus there. Just realize that might be a bit confusing. So it's between over 2 and less than 16 kilos. And these are the important ones. So for class 1 obesity, they're talking about over 2 and less than 6 kilos weight gain. Class 2, it didn't matter whether you lost a bit of weight, so you could go above, so you could lose up to 4 kilos or not gain more than 4 kilos, and you were in the beneficial outcome group. And then class 3, they found it was less than 6. This is likely a small number effect because the numbers were going down, clearly because the percentages go down. In terms of ratifying this, there is still a little bit of ongoing debate, but just as an example, in the Diamond Clinic, we have long advocated for no weight gain throughout pregnancy. That's in the extreme group, but it's interesting to see, and it's been long suspected that this would probably be the case, and this is a really, really impressive paper that has managed to get that sort of further confirmed. What happens if you don't reach those ideal weight targets? And here's perhaps one of the slightly more depressing messages of my talk, because as I've said before, one of the things we can do is we can give advice about not putting too much weight on. But in terms of pregnancy outcomes, it actually, it kind of doesn't make that much difference. And the main message being here is that it's hard to overcome the risk profile that you attain when you start your pregnancy. And that if you start your BMI, if you start pregnancy with a BMI of 35 and you go absolutely ideal weight gain, you are still better off in terms of risk to have a BMI of 30 compared to 35 at the beginning of your pregnancy. So if you gain above the recommended amounts, then you can see there's certainly a percentage change, but those aren't massive differences. And then if you gain below the recommended weight gain, and this is all comers, by the way, this is not just obese women, it's looking at all comers. So if you put less weight on, you'll have a slightly smaller baby on average, but we're not looking at dramatic effects. And as I said here, the take-home message is that it's pre-pregnancy BMI that strongly predicts your risks. All right, I'm going to jump through some of this a little bit. I've put resources here for you to get. I really like this. Women really like these posters. They're very easy to understand. They're actually out of Canada, and there's a lot of good data comes out of the Canadian system. But do have the conversation. 15 to 30 minutes exercise a day, not window shopping. Although actually there is actually some evidence to suggest that even small amounts of exercise, if you add it up, is still beneficial. But you do want to be doing something a little bit more than that. And as long as the woman doesn't have pre-existing major cardiovascular issues, it's fine. It tends to be self-limiting. And interesting, in terms of aggressive exercise in pregnancy, it's elite athletes that run into the most trouble, because they don't listen to their bodies and they push through the lactate pain. If you struggle with what to say around diet as part of this advice, again, there's loads of really, really good advice out there. And if you just search for Eat for Healthy Pregnancy, it's again, pictures are very, very well received in terms of what you should or shouldn't be eating. I'm only briefly going to touch on, I mentioned before that one of the things that we know probably links to the increased stillbirth risk is that we miss your growth restriction. So surely the way around that is doing an endless number of scans. And the problem is it doesn't solve the problem. So we've actually just published out of Western a study that looked at if you adhere to the Victorian guideline, and the Victorian guideline says that if your BMI is over 35, you should have a routine growth scan at around about 35 weeks. That was based on an expert group sitting around a table having a conversation in 2011. And I was part of that conversation. We decided there was something we needed to do because we were seeing lots of women with missed growth restriction. I can tell you, unfortunately, that we've just reviewed it, and our ability to detect a significantly small baby off that routine scan is terrible. The positive predictive value for a low birth weight is atrocious. Even the positive predictive value for a macrosomic baby is as good as tossing a coin. And so we really struggle with this still. And I'll come back to what can we do with that. But unfortunately, it's sort of, you know, who knows? So we have our routines, but is it worth it? We're thinking about it. Should we do things differently at the end of pregnancy? Well, this may be the route to decreasing the stillbirth risk, but there are some knock-on consequences to that. There's pretty strong movement, I won't say evidence, other than you can see what happens here to the stillbirth risk. If your BMI is over 50, it screams up the moment you go beyond 39 weeks. The statewide guideline suggests delivering before 39 weeks. What about if your BMI is over 40? The Western Health Guideline says deliver before your due date. And then we can't really offer any sensible advice around what happens if your BMI is over 30. Part of the reason this may be beneficial, of course, is you interrupt the natural sequence of missed growth restriction leading to stillbirth. And that's actually why these graphs shoot up. You just haven't spotted the growth restriction. And then the other part of the problem here is what about macrosomia? Unless somebody wants to particularly talk about it, I will leave macrosomia alone. So this kind of area is a little bit up there and hard to be specific about. Just quickly, there's a very strong link between difficulties establishing breastfeeding and BMI, and it's a straight line. For the higher end women, they would be advised to be going home if they've had any degree of complexity around their birth, and for between 4 and 6 weeks if they've got class 3 obesity and they've had a cesarean, and extended antibiotics, all sorts of protocols around that. It doesn't seem to matter what you do as long as you do something to decrease that postnatal infection risk. We've talked about GTT, strong link with mood problems, exaggerated postnatally. And you have to pick your moment, I think, to talk about weight management for the next pregnancy. But given what we've said, that it's the most powerful indicator of risk also in your next pregnancy, it needs to be thought about. And then there's the issues around contraception. I've only got a couple more slides. And I'm going to be very brief around this, but I'm going to give you a resource to look at it. So the underweight issue is kind of challenging, partly because it's a bit more of a mishmash in terms of what you're actually looking at. And this is a really, really nice study. It's publicly available, so you don't need UK college access. You can just find the link on the internet. It's freely available, and it's a very nice summary of the management of pregnancy for women who have a BMI under 18.5. For most women, that's actually normal, and certainly with Southeast Asian population we look at after in Western Health, that would be the vast majority. One of the problems with underweight women who are underweight is there something more significant going on, and so part of the management is to go looking for a cause and not presume. I lifted this sentence. I was really intrigued by that figure. I think it's probably quite a complex calculation that sits behind it, but it kind of struck me that being underweight isn't just isn't nothing. The main concern that we have for being, if you're underweight, is that they're smaller women, a bit like bigger women tend to have bigger babies, smaller women tend to have smaller babies. Some of that might be constitutional, but then you don't want to presume that because you might be missing the growth-restricted baby. And the single biggest risk factor, if you're taking history and you see a woman in her first or early second trimester, and you want to predict her chance of having a preterm birth, her weight is the single biggest prediction in her first pregnancy. The single biggest prediction in the second pregnancy is a past history of preterm labor, but in a first pregnancy, it's up until you have your anomaly scan and your cervical length measurement, you can get more information from weight than anything else. And so in general management, you're looking at an underlying cause, and again, you'll know much more about looking for those things than I do. We would be cautious about going actively looking for the growth restriction. It is good to encourage the appropriate weight gain, and unlike in the high women, trying to encourage weight stabilization, which is challenging, you can get appropriate weight gain in women who are underweight. But other than that, it's actually, and it was interesting, this article, if you read it, as I said, it's very recent. They were sort of alluding to the fact that maybe the underweight group's a little bit of a missed category. And then I'm just going to say a little bit about, and again, send you in the direction of this resource. Suresh actually mentioned this paper. It's a really good summary of what to do, not so much about what are the problems with bariatric surgery and then becoming pregnant. It's very practical advice of what to do. And so I'd encourage you to download that. As part of the Diamond Clinic, although we look after that very high end, we also look after women who've had bariatric surgery within the last 2 years prior to conception. And the reason for that is that we have the same team that need to look after you, and that's essentially obstetricians with an interest and a dietitian who can see you and help with reminding us what the unbelievably long list of micronutrients are that we have to go looking for. I wonder how common it is out there. I tried to find out some data about sort of frequency of presentation. I didn't get it for this talk, unfortunately. The latest information I got was the operations per year has gone up from 9,000 to 27,000 in Australia in the last 10 years. There is really good evidence about improvement in pregnancy outcomes, so it works. There are still ongoing debates about the long-term benefits of weight loss surgery, but from a pregnancy risk reduction point of view, it works. And again, I'm not going to go through this. It's just to say the really nice thing about this paper is it breaks it down. So you've got laparoscopically assisted balloons, you've got gastric bypass operations, duodenal switches now. So there's various levels, and the level of anxiety around the chance of having a significant micronutrient deficiency goes up across that group. But again, I'm not going to necessarily talk through it, but just encourage you to be mindful. And again, the earlier you can jump onto those things, probably the lower the risk of any risks from those issues. And apologies, I didn't realize I should put 2 slides in. All right, so I'm going to hand over some questions in a second. So probably main message, just to stress, is the stillbirth risk around being overweight or obese. and encourage you to be part of the solution in terms of how we try and reduce the prevalence of high BMI and pregnancy. And I'll leave that lot there, and we can do questions and people can look at that.
Great, thanks very much, Glenn. That was a really informative talk. I think I've heard you talk a couple of times on the obesity issue, and I think something that us GPs, we're also seeing some of these younger women who've, you know, had eating disorders and challenges through COVID, and I guess they're going to be our patients who are going to be pregnant sort of in the next sort of 5 to 10 years. So I think, I don't know what your thoughts are about that group of women, and if we need to be doing anything else specific.
Yeah, no, look, it's a very good point. So there's, in fact, there's a couple of things that we know have happened from COVID. There's the increasing eating disorders, but actually BMIs have gone up. So we're seeing maternal BMIs in some statewide data coming out now showing that has crept up, and newborn baby weights have actually crept up as well. So I think you need to be on the lookout for it. There is actually some advice. I think it's actually in that paper around eating disorders. And one of the challenges around eating disorders is the woman with low birth weight that's presenting to you in early pregnancy got hyperemesis gravidarum, or actually has she got an eating disorder? And I think that you just have to bear that in mind and have the conversation. That one of the myths is that if you've got an eating disorder, you're infertile and therefore you won't be presenting for antenatal, and that's simply not true.
Thank you. And I just wanted to clarify, the BMI we're talking about is the BMI when we kind of get them for their first visit, is that correct?
Yeah, so again, lots of discussion around this in the literature. I wouldn't be worrying about whether it's an estimated pre-pregnancy BMI or the BMI that you're looking at in early pregnancy. They're going to be the same thing, and without, you know, I don't want to be unnecessarily flippant, but if your BMI on presentation is 35 in early pregnancy, it wasn't in the healthy weight range 2 months earlier. And so it really doesn't matter. Actually quite important point, which leads to lots of confusion, is that all of the risk data that I've presented to you is based on that early pregnancy, or in some studies called your pre-pregnancy BMI. It's not based on what your BMI ends up at 40 weeks. And that becomes really challenging because lots of smaller services have a BMI threshold. And then if you put weight on in pregnancy, they try and kick you down the street for your birth. And I'm regularly having arguments with people that that's illogical, because it's not your BMI at late pregnancy that determines your risk. It was what your BMI was in early pregnancy. But I don't always win that argument. I can see Suresh has his hand up.
Suresh, do you want to
yes,
come off mute?
I have unmuted. Can you hear me now?
Yeah.
Dean, you were kind enough not to interrupt my talk, but I'm going to give a shout out on the 2 points you made and add a third one. That the shout out is, as much as the GDM testing and initial 12-week GDs and stuff, I think anyone has a risk for preeclampsia. The aspirin concept, I think, is slowly creeping, but it could be a lot better. We get to see them at 16 weeks with a BMI of 35 plus and not on aspirin. And with a history of preeclampsia in the past, that's even more important. And I agree with you completely on the calcium. I usually stick to 600 milligram times 2 tablets a day, wearing my medical obstetric hat. And the last point I'd like to raise is the NEJM article about exercise reducing the risk of preeclampsia. I think it's 20 minutes or 30 minutes 4 times a week, if my memory serves me right.
Yeah, I think the problem, Suresh, with those studies is that they're in controlled environments. And they have a whole team around them that are having the conversation, ringing you up. So the only really good weight intervention data that has ever been produced comes out of China, where you get referred to a clinic when you're 1 day pregnant, and you're obliged to adhere to the program. This is not the real world. But it has a really significant effect on limiting weight gain, because you've got to get people really early. Otherwise you're sort of you're losing. And as I say, I think the problem with recommending 4 times a week is, and I may be excessively cynical, it happens certainly less than 4 times a week, if at all. Because I think there's something in there about messaging, because there's no harm to doing it more. And so if you say, I think you should be looking at exercise every day, not expecting you to run marathons. Are you doing anything at the moment? Have a conversation about that. If you're not, well, why don't you just start with a 15-minute walk every day and push yourself a little bit, so that you're just having to just take a little breath when you get home, and then we can talk about it next time. That's how I go with the conversation.
Agree.
So in the interest of time, I'm conscious of us finishing on time. There's a few questions still there, Joe, but what I propose is that we take them on notice and get them answered offline. And when we send out the video in a week's time, perhaps we could send some resources answering those questions. Are you happy with that, Glyn and Joe?
Yeah, absolutely. I might just answer one quickly, if that's okay. Just the most recent one I just flicked up was around that.
It's your time I'm worried about, so go for it.
Yeah, so I have a couple of patients. The question is, a couple of patients with previous GDM at Joe and Kern who were told no need for early OGT at 16 weeks, just repeat the fasting glucose. The confusion around that, and it has been confusing, and I'm part of this decision making, and I find it really hard to remember, is that we stopped doing GTTs as part of the COVID management protocol because of sitting in a waiting room for 2 hours. So we moved over to fasting sugars and HbA1cs. And that's probably why you're seeing some different advice coming out. Now, we have just gone back to business as usual with OGTTs. And it is an interesting situation because, and I think Suresh touched on it, I certainly saw some questions. Could we be using HbA1c? Is it the same? We don't actually know. And we have a research grant application in at the moment to answer that question, because women absolutely hate the glucose tolerance test. And if you've never had one, you should try it. I did it and I'll never forget it.
Try doing it pregnant.
If I could. All
right. Okay, thanks very much, Glyn. That was a fantastic presentation. So we'll get Glyn to answer some of those questions offline for his homework, and I think Glyn has got another meeting to run off to. If everyone could just stay online, because we've just got a couple of updates just around the changes on the services, just a couple of, and then about re-credentialing. So again, thanks Glyn and Suresh for fantastic presentations. And Arzu was here earlier on. She had to run off to, she's on call, and Inez and Karen too. So, and of course, Olivia behind the scenes at the PHN, who's, you know, with Karen and I panicking and trying to juggle our clinic load today. So anyway, on to our updates. So, so at the women's, I think Inez sent a notice out earlier on in the week that there's now a public fertility clinic. The criteria is a little bit restricted, but, you know, I think go onto the website and have a look if you've got any patients who may be needing that service. Inez is going to be on leave in December and January, so Mary Dare, who covered while Inez had a long service leave, is going to come and provide some cover and help us with the re-credentialing, so the challenges. So at Western Health, our update is that we have amalgamated with Djerriwarrh, and that's why Karen has come and joined the team, so we're very lucky. So as part of that change, we will be commencing centralised triage for patients who are wanting their deliveries through Sunshine or Bacchus Marsh, and patients will be allocated to the sites based on their home address and the clinical need. So if you're a high-risk patient who lives up at Bacchus Marsh, well, you probably will be triaged down to deliver at Joan Kerner. But if you're low risk and you live in Bacchus Marsh is where you're going to be triaged to. So just to give GPs that kind of information, because we're going to need your support as we go through those changes. You know, same teams, registrars and things rotate through Bacchus Marsh. So lots of changes happening up there. As also part of that, you know, as Glyn said, the demand is huge at Sunshine. And we're still getting referrals for lots of patients from far further afield that need to come to Sunshine. So we've worked with some of the other health services, and some of those patients' referrals that may come from Craigieburn or Calcallo will be redirected to the Northern or back to the Women's. So if you do send a referral in and the patient is redirected, then the GP and the patient will be receiving a notification. And as Glyn said, we have from November, we're going back to doing glucose tolerance tests rather than the fasting sugar and the hemoglobin A1C. So now re-credentialing, I know a lot of you have been thinking, well, it's coming up and we haven't heard yet. So there will be an email coming out from the Northern, so they're sort of the coordinators this time round. So please be on the lookout, and we will be asking you to register through Try Booking again. We had hoped that we would be able to use CGov, which is a bit more streamlined, but we just can't get that up and going quickly enough. So we're all going to be involved in it. So you may hear, once all your documents are in, you may hear from one of the 4 sites. If we've got any questions, you need to show evidence of 5 hours of pregnancy-related education. So that's effectively 10 points. So, and I know in the past there's been confusion about what's pregnancy-related, you know, is it gynae, is it women's health? So I think we do have a list on the websites at the Women's and Sunshine or Western of some of the education that I've been trying to gather and have available for people to have a look at. So have a look there if you're not sure. Tonight was 2 hours, last week was 2 hours, and there's been other sessions, and some of them are on the PHN website. You can watch those and record them in your college, log them as a self-recording. And I also noticed that the Australian Journal of General Practice, they've got some articles on perinatal stuff. So that's another option to do that and record some points. So when you come to send in, we'll need that evidence. We'll need your medical indemnity insurance certificate, and there'll be the signed agreement that we need to have from you. We will check your APRA registration. And this is just a reminder that every now and then we do get notification that somebody has had some warnings from APRA, and please, if that happens to you, please contact one of us so as we can step you through the process and make some decisions about whether that's going to stop you from continuing to provide shared care. So I think that's all from me. I don't know if anybody's got any questions about any of that. If you just want to pop those in the Q&A and we'll see. Let's see. No questions. All right. So these points, the PHN will go through the list of everyone who's been here. It'll appear on your college statement in about 4 weeks' time. Have a look if you need extra points on the PHN website for the YouTube recordings of past education sessions. Thank you very much. So hope you've all really enjoyed our session tonight and last week. So I think we've had some really good presentations and some things for us all to go off and think about, and especially around care of patient with GDM who are in shared care. So work for us to do. So have a great night, everyone. Thank you.
Thanks. Bye, everyone.
Thanks, everyone.
Bye.
Bye.